In the physiology of pregnancy lesson, we talked about how systemic vascular resistance falls, and so blood pressure in a pregnant woman should be lower than baseline. In medical disease, we talked about how to manage someone who has hypertension before she becomes pregnant. The thing is that an elevated blood pressure is pathologic, and you need to use that as a marker for the onset of the preeclamptic to eclampsia spectrum diseases. Preeclampsia and eclampsia are all about vasoconstriction. When you have vasoconstriction, you've got an increased systemic vascular resistance and your blood pressure will rise. The real problem, though, is that you're going to have vasoconstriction everywhere, and so organs can be impacted, including the brain and baby. So what we're going to do in this lesson is review the different types of hypertension so that you can separate the benign diseases of high blood pressure from the more severe diseases of preeclampsia through eclampsia and finish off with HELLP syndrome. We're going to be discussing these diseases in a table. We're going to talk about the disease itself, the blood pressure, the minimum blood pressure, which categorizes the disease, the timing of onset, and whether or not it is sustained, what the urine shows, whether or not there are alarm symptoms, how to treat it, and what follow-up is necessary. Urinalysis alarm symptoms. As we get into preeclampsia, both with and without severe features, we'll talk more about what the alarm symptoms are and why the urinalysis matters. Let's start off first with transient hypertension. Non-pregnant patients, pregnant patients can have an elevated blood pressure. And an elevated blood pressure is defined by one that is greater than 140/80, and you need only one to make the diagnosis. The thing is that white coat hypertension, someone worked out a little bit too hard, was running across the street, it is going to be a non-sustained elevation in the blood pressure. Whether it is sustained in the same visit or not, if it is non-sustained at the same visit, great. If you bring them back and they remain normotensive, that reading was off, transient hypertension. And since it's not really a disease state, there's not going to be anything on the urine, there will be no alarm symptoms, and you don't really need to treat it other than to keep a log, which is ambulatory BP monitoring. Just have her check her blood pressure at home and bring in the log at each normal visit. That's different than someone who has chronic hypertension. This is what we talk about in the medical disease lesson. Same cutoffs, 140/80, but this is going to be a sustained elevation in the blood pressure, but the onset is before 20 weeks. 20 weeks is going to be our cutoff for all these diseases. Chances are someone who has chronic hypertension is going to know it before she gets pregnant, but the cutoff is 20 weeks. Because it's just hypertension, the urinalysis will not show anything, she'll have no alarm symptoms, but you will have to treat her. And remember, a lot of medications that treat hypertension are teratogenic. The right answer, if you see it, is alpha-methyldopa. The other medications you can use, which are not wrong, but this alpha-methyldopa is more correct, would be labetalol and hydralazine. The thing is that you're going to use elevated blood pressure as a marker for someone who could be developing preeclampsia. So the follow-up is going to be close monitoring of that patient, and you can no longer use the blood pressure as a marker for her developing a more severe disease. So what you're going to need to do is keep track with more frequent urinalysis and ultrasounds assessing for intrauterine growth restriction, and you're going to have more frequent assessments. This is why someone with a medical disease sees a specialist. The other disease that is benign, which you don't know it at the time that it happens, is gestational hypertension. You are still going to have the 140/80, but it is going to be sustained, but it is going to occur after 20 weeks. But if she has gestational hypertension, she will have no changes on her urinalysis and will not have any alarm symptoms. It's the same thing as chronic hypertension in the sense that she's going to need frequent urinalysis and ultrasounds with more frequent follow-up. The only difference is that this can progress to preeclampsia. The thing is, you don't know at the time you diagnose her if she's got preeclampsia or not. At the time right now, she could develop preeclampsia. Retrospectively, you will realize that one, gestational hypertension, is not the other, preeclampsia. But at the time right now, unless you do urinalyses, you won't be able to know which direction she's heading. And now we're going to move into the eclamptic range diseases. And I like the old nomenclature, mild pre-E and severe pre-E. And then, of course, eclampsia. Mild and severe pre-E made it sound like there were two discrete diseases. And the new nomenclature says the same thing, but it effectively communicates that it is more of a spectrum than discrete diagnoses. While you are studying for step 2 and at the M3 level, I want you to see them as discrete. We'll talk more about reality at the very end of the lesson. Now instead we call them preeclampsia without severe features, PEC, or SPEC for preeclampsia with severe features and still eclampsia. When you have reached the level of hypertension, 140/80, again, it's an or statement, that categorizes preeclampsia without severe features. The difference between gestational hypertension and preeclampsia is not the timing, because they're both going to be sustained after 20 weeks. And as we'll realize, all of these diseases are going to be sustained elevation in the blood pressure after 20 weeks. What separates it is the presence of proteinuria, which is why we're mentioning the urinalysis above. The cutoff is 300 milligrams per deciliter. And a urinalysis is indicative, add it to the elevated blood pressure, that person has preeclampsia. But preeclampsia without severe features has no alarm symptoms. It being the least severe of the diseases, you don't really have to worry about intervening. That is to say, if she's term, go ahead and deliver. Greater than 37 weeks, deliver. If she's not term, less than 37 weeks, you just wait. You're going to have more frequent follow-ups, usually weekly, and you're going to continually screen for alarm symptoms and worsening of the proteinuria. If she progresses to preeclampsia with severe features, then you start talking about actually intervening. Preeclampsia with severe features has an increased blood pressure, 160/110. Again, it's an or statement, sustained after 20 weeks. Severe range of proteinuria reaches 5 grams per deciliter, and now there are the onset of alarm symptoms. I'm going to keep this clean in a table that lines up well and explain what's real afterwards. If you have diagnosed preeclampsia with severe features, you need to give magnesium and deliver. The age is irrelevant. Usually, this is vaginal by induction. If you have eclampsia, it doesn't matter what the blood pressure is, when it's happening, or what the urinalysis is. All that matters is that she is having active seizures. This is not someone with epilepsy who happens to be seizing. This is someone who did not have epilepsy and has progressed full-blown to eclampsia. This person needs magnesium for seizures and needs to be delivered. And this is usually by emergent C-section. You don't have time to mess around because if mom dies from her seizures, baby dies too. And then one disease that very commonly gets tested along with eclampsia, and you'll see why in just a second, is HELP syndrome. HEL LP. HELP stands for hemolysis, elevated liver enzymes, and low platelets. This is treated exactly the same way as eclampsia and has a similar pathology. Why are they tested very similarly? That doesn't have anything to do with hypertension and proteinuria. The reason is because we're talking about severe features, you need to know what those severe features are. And you'll see why HELP gets lumped in this lesson. Severe features are going to be decreased platelets, increased liver enzymes, right upper quadrant abdominal pain. This is caused by stretch of Gleason's capsule. As blood flow decreases to the liver, LFTs may double, and then the pain is because of the inflammation and the stretch of the capsule around the liver. Low platelets, elevated LFTs, and some hemolysis during pregnancy, you've got HELP syndrome right there. But you also need to look out for an elevation in the creatinine. And remember, normal creatinine should be lower in pregnancy, 0.4 to 0.8. If you see what's usually considered a normal creatinine, greater than 1.1, or a doubling of her creatinine in someone who has no known kidney disease, that's a sign that there's problems with her kidneys and you need to consider preeclampsia. Other things you're looking for are pulmonary edema, headaches, and vision changes. Remember, the pathology is all about vasoconstriction. If you vasoconstrict, your blood pressure goes up, which is going to cause the heart to work harder and lead to pulmonary edema. If you clamp down on the renal arteries, you're going to worsen renal blood flow. If you decrease the blood flow to the brain, you're going to get headaches and vision changes. And all of this has to do with blood pressure, so a severe feature, in fact, is a blood pressure of 160 over 110. We said mag and deliver, right? So what is mag? What does that mean? Magnesium is used to prevent seizures. Turns off everything. And you will be doing mag checks, likely, on your obstetrics rotation. And the idea is you want to assess for decreased deep tendon reflexes. If you lose deep tendon reflexes on magnesium, that is a sign that the magnesium is continued, you're going to decrease her respiratory drive, cut off the diaphragm, and have her not breathe. Not good. If you see decreased tendon reflexes, you're going to give calcium as the antidote. Magnesium prevents the seizures in order to get baby out. Now we're going to talk about the real stuff. I promise I would. What you generally need to do is balance the risk and the benefit. And it needs to be the risk of baby coming out versus the benefit of baby staying in. The risk of baby staying in versus the risk of baby coming out. The big thing on the risk side is going to be mortality and morbidity. The more severe the disease, the worse the risk of dying or losing the fetus, the more likely you are to rush. You're going to do this based on two things: the number and severity of severe features. The higher the blood pressure, the worse the proteinuria, the worse the headaches, the worse the pain or the elevation in the LFTs, means that the disease is progressing. This is why we talk about preeclampsia without and preeclampsia with severe features, because it provides more of a spectrum. The other thing you're going to do that helps you decide whether you induce or do C-section is going to be stability. And it's stability of mom versus baby. The idea is a crash section is done when mom or baby is about to die. If both are doing well, even though they've got a lot of severe features, it may be okay to induce. But you need to weigh the risk based on severity, number of severe features, and stability of mom and baby against the benefit of fetal development. And you should see the benefit of fetal maturation like this. If your term, that is 37 weeks, there's no benefit to staying in. So no matter how it's insignificant to her preeclampsia, it is worth simply delivering. Now we agree upon 20 being an abortion, so there's certainly no benefit there. And for the test, let's ignore politics, let's just say between 20 and 37 is viable. If you have 20 to 37 weeks, then what you want to consider is how much will baby benefit from staying in. This triangle represents the amount of benefit, with the width being benefit. The closer to 24 weeks you are, the more likely baby is to benefit from maturation, so longer baby should stay in. The closer to term you are, the less likely baby is to benefit, and the more likely you are to deliver. Very complicated, right? And it's going to be based on mom's particular preference, how sick you think she is, how bad she's doing, what the risk factors are, what her velocity has been. And so as you study for the step and at the M3 clerk level, what I want you to hear is this. Preeclampsia without severe features, no big deal. You're always going to wait unless it's term. If you have preeclampsia with severe features and it is any of the severe features, the test is not going to throw you curveballs, then you should do MAG and deliver, and chances are she's not sick enough to need C-section, so it will be induced. You have time to stay and play, unless they imply fetal distress. If you have eclampsia on the test, full-blown seizures, mom's in trouble, the only thing that will get her to live is getting baby out, so you do a C-section. In reality, it's more complicated. So in addition to that learning, what I also want you to be able to do is recognize transient, chronic, and gestational hypertension based on the blood pressure range, whether or not it is sustained, and it comes before or after 20 weeks. And then always keep in mind the medications you can use, alpha-methyl-dopa, labetalol, and hydralazine to control the blood pressure. The usual medications like diuretics, ACE inhibitors, ARBs, and calcium channel blockers should not be used in pregnancy. That is eclampsia.